You're here because you want to get up to speed quickly and thoroughly on a specific medical topic. Today, we're diving deep into penetrating aortic ulcers, or PAUs.
Yep, PAUs.
Our expert guidance comes straight from the weighty Rutherford's Vascular Surgery and Endovascular Therapy, 10th edition.
A really solid source.
Think of this as your express route to understanding exactly what PAUs are, who they tend to affect, how they're diagnosed, and, well, the latest in treatment.
Our goal is really to pull out the essential knowledge from these chapters, give you a clear, insightful understanding, without getting totally bogged down in jargon.
Okay, let's kick things off with something you might find surprising. Even though PAUs are a serious issue affecting the aorta, the body's main artery, they weren't really clearly defined as their own distinct condition until, what, 1986?
That's right, in 1986, Shanann and Stanson's report really distinguished them. Before that, things were a bit murkier.
And get this, they're actually less common than aortic dissections, affecting just maybe 2 to 3% of individuals experiencing what's called Acute Aortic Syndrome, or AS.
Mm-hmm. And AAS, that's the umbrella term, right? It covers acute aortic dissection, AD, intramural hematoma, IMH,
Yeah.
and our focus today, the PAU.
Exactly. So the key takeaway here is that while you might not hear about PAUs as often as dissections, they're a distinct and pretty serious threat to the aorta.
What's fascinating here is how a PAU actually develops. It's essentially a localized ulcer in the aorta that begins with the buildup of fatty deposits, what we know as atherosclerotic plaque.
Okay, plaque.
Yeah, this plaque can then erode its way through the innermost layer of the aortic wall. Think of it like a focused area of damage starting from within the artery lining.
So it's like a small, very specific, but potentially dangerous erosion in the aorta's inner wall, like a little pothole almost.
Kind of, yeah, a pothole that goes deeper. And as you hinted, while significant plaque is often involved, it's not always obvious on imaging.
Right. The sources say only about half of PAUs found on scans are directly linked to, like, clearly visible atherosclerotic lesions.
That's true.
Yeah.
And the ulcer itself, it can actually extend all the way around the aorta circumferentially, or it can run lengthwise, longitudinally.
This raises an important question. What happens after this initial ulceration occurs? Where can it go?
Well, a PAU can progress in a couple of key ways. It might disrupt the middle layer of the aortic wall, the media, leading to what's called an intramural hematoma, or IMH.
Right, the bleeding within the wall layers. We mentioned that.
Exactly. It's contained in the wall, distinct from a full tear that creates a separate channel like in a dissection.
Okay. And the other way.
Or, if the ulcer goes all the way through the outer layer, the adventitia, it can lead to the formation of a pseudoaneurysm.
Pseudoaneurysm, so that's like a contained leak.
Yeah, basically a collection of blood contained only by the outer layers or surrounding tissue. That's a more fragile situation than a true aneurysm, which involves all layers of the vessel wall bulging out.
Got it.
And interestingly, the sources note that up to, well, maybe 80% of PAUs might have an associated IMH, often contained somewhat by calcium deposits in the surrounding area.
Wow, up to 80%. That's a really significant overlap. That really highlights how intertwined these conditions can be.
It absolutely does.
And it underscores why it's so crucial to distinguish between a PAU on its own and a PAU that occurs with an IMH. The likely outcome, the prognosis, and the best treatment approach could differ. Right?
Definitely. Now, PAUs might sound a bit like aortic dissections, but the experts make it clear they are not exactly the same thing.
How so?
Well, unlike dissections, PAUs don't necessarily occur at those points in the aorta that experience the highest hydraulic stress, the points with the most blood flow forward.
Oh, okay.
And they're also not typically linked to the genetic conditions we often see with aortic dissections, like Marfan syndrome. That's a key distinction in understanding their underlying causes. They seem more related to that atherosclerotic process.
That's an important difference to keep in mind. It's also interesting that we don't have a lot of tissue samples from PAUs to study under a microscope. Why is that?
Well, it's mainly because they're frequently managed with medication or increasingly minimally invasive endovascular procedures. So surgeons aren't always removing tissue like they might in a big open repair.
Right, less surgery means fewer samples.
Exactly.
Yeah.
But the research that has been done does show the presence of macrophages and inflammatory markers in the affected area.
So there's definitely inflammation going on there.
Yeah, it really reinforces the idea of an active inflammatory process happening at the site of the ulcer.
And it's crucial then to tell PAUs apart from other things that might look similar on a scan.
Absolutely. You need to differentiate them from true pseudoaneurysms, saccular aneurysms, which, as we heard, PAUs can actually develop into.
Yeah, about a quarter of cases, you said.
Roughly, yeah, nearly 25% of abdominal and thoracic PAUs degenerate into saccular aneurysms, and you also need to distinguish them from mycotic aneurysms.
Mycotics, those are the infected ones.
Correct. Caused by infection, and they usually come with systemic signs of inflammation, like fever, elevated white counts. PAUs typically don't present that way unless there's a secondary infection, which is rare.
So it's a very specific type of aortic damage occurring in a particular context, usually atherosclerosis.
Precisely.
Okay, so who are we talking about when we talk about PAUs? Is there a typical patient profile?
The data paints a fairly consistent picture. PAUs are relatively uncommon within that whole spectrum of acute aortic syndrome, accounting for somewhere between, say, 2 and 8% of cases.
So not the majority by any means.
No. And the large majority of these tend to be located in the descending thoracic aorta. That's the part of the aorta running down through your chest.
Okay, descending thoracic.
Yeah. To give you some perspective, in studies that use specific imaging, like transesophageal echo or reviewed aortograms for suspected dissections, PAUs were found in only around 2 to 3% of patients, much lower than actual dissections.
So they're less common, often in a specific spot. What about the people they affect? Age, gender.
Typically, PAUs affect older men, usually in their 70s and 80s, with an average age right around 72.
So older than the average dissection patient.
Generally, yes, a bit older. And just like with aortic dissection, there's a male predominance. About 2/3 of PAU patients are men.
Interesting. Any difference in outcomes between men and women?
Well, one study suggested women might have worse outcomes, but a larger study actually found no significant gender difference in survival after endovascular repair.
So the jury might still be out a bit on that one.
Okay. And are there any common health issues that often go hand in hand with PAUs, comorbidities?
Absolutely. Hypertension, high blood pressure is almost a universal comorbidity. It's nearly always there.
Wow, almost universal.
Yeah. You also commonly see a history of smoking, coronary artery disease, CADS, and COPD, chronic obstructive pulmonary disease.
Okay, so the usual vascular risk factors.
Pretty much. But what's particularly notable, and something we touched on, is the strong link with abdominal aortic aneurysms, AAAs.
Right, you mentioned that earlier. How strong is that link? The sources mentioned that up to 50%, half of patients with PAUs also have an AAA. That's a much higher rate than we see in patients with acute aortic dissections.
That's a really striking association. Half is huge.
It really is. And it's a critical insight for clinicians. If they find a PAU, they should definitely be looking closely for a AAA and vice versa.
So we're talking about older folks, predominantly men, often with high blood pressure, maybe smokers, and potentially in AAA lurking somewhere else.
That's the typical picture, yes.
And you mentioned the descending thoracic aorta as the most common location. Where else do PAUs tend to show up?
After the descending thoracic aorta, the aortic arch and the thoracoabdominal aorta, the part crossing the chest and abdomen, are the next most frequent sites.
Less common elsewhere.
Right. PAUs in the ascending aorta, the part coming right out of the heart, are less common. And involvement of the aorta below the kidneys, the infrarenal aorta, or the iliofemoral arteries in the legs is relatively rare, only about 4% of cases.
Okay. And is it usually just one ulcer, or can people have several?
While it's often a single event, it's worth noting that somewhere between 17 and 22% of patients actually present with multiple PAUs.
Multiple PAUs, that sounds like a complex scenario. Now, how do these PAUs make their presence known? What are the typical signs and symptoms?
Well, the way a PAU presents can vary quite a bit from person to person. It's not always straightforward.
Okay.
Some experience severe chest or back pain, really intense. Others might have more subtle symptoms, maybe just shortness of breath.
Subtle symptoms could be tricky.
Very tricky. And if the PAU is located in the ascending aorta, the symptoms can actually mimic those of an acute coronary syndrome, a heart attack. You might get chest, neck, or jaw pain.
So it could easily be mistaken for a heart attack in that case?
Precisely. That's a really important differential diagnosis to consider.
What's more common, though?
More commonly, the presentation is similar to an acute aortic dissection, that sudden onset of tearing or ripping pain in the back, often between the shoulder blades.
Okay, that classic dissection pain description.
Exactly. And if the abdominal aorta is involved, patients might experience abdominal pain. There are even rare reports of more severe symptoms, like coughing up blood, hemoptysis, or vomiting blood, hematemesis.
Oh, right.
If the PAU ruptures and forms a connection, a fistula, with the bronchial tubes or the esophagus. But that's quite rare.
Those sound like very serious, thankfully rare complications. But are PAUs always symptomatic? Do they always cause pain?
Interestingly, no. The sources indicate that some PAUs are entirely asymptomatic. They're just found incidentally when someone is getting imaging, like a CT scan, for a completely different reason.
Really? How often does that happen?
One meta-analysis, looking at patients who had endovascular repair for PAU, found that around 9% were asymptomatic at the time of diagnosis.
That's a significant number, almost 1 in 10. So you could have a PAU and not even know it.
Exactly. Which raises questions about screening and management, doesn't it?
It definitely does.
Yeah.
What about the risk of rupture? Is that always a major immediate concern?
The risk of rupture seems to depend quite a bit on the location of the PAU.
Okay.
For example, studies have reported a higher rate of emergency presentations with rupture in symptomatic PAUs located in the descending thoracic aorta. Makes sense. Higher pressure, maybe?
Maybe. What about lower down?
Well, PAUs in the abdominal aorta might actually have a more benign course. Some studies reported no ruptures at all in their series of abdominal PAUs.
Huh. So location really matters for the danger level.
It seems to, yes.
And how can doctors use a physical exam and basic lab tests to help figure out if it's a PAU versus, say, an aortic dissection, especially before getting the big scans?
Yeah, the physical exam findings can offer some valuable clues, though they aren't definitive. In PAU patients, the peripheral pulses, in the arms and legs are typically normal and symmetric.
Okay, equal pulses.
Right, and their neurological exam is usually intact. They're also less likely to have elevated levels of lactate or creatinine in their blood, which can indicate poor perfusion or kidney issues often seen in dissection. And you wouldn't typically see evidence of new aortic valve regurgitation, the heart valve leaking, which can happen if a dissection affects the valve.
So absence of those things might lean towards PAU?
It might steer you that way, yeah.
Yeah.
In contrast, those findings, unequal pulses, neurological deficits, elevated labs, new murmur, can sometimes be present in someone with an acute aortic dissection. So while imaging is definitely the key,
Right. CTA is king here.
those initial assessments can help point doctors in the right direction and assess the urgency.
Good point. Now, let's circle back to how PAUs connect with other aortic problems. We've already heard about the strong link with abdominal aortic aneurysms. What else should we know?
Yeah, that frequent association with intramural hematoma, the IMH, is a really significant point we need to emphasize.
We mentioned up to 80%, but some reports are lower.
Reports vary quite a bit, yes.
Mm-hmm.
Anywhere from 22% up to maybe even 94% in some series, though that high end seems like an outlier. But the point is, it's common.
Okay, very common.
And remember, both PAUs and IMHs are contained within the aortic wall.
Yeah.
There's no intimal flap, no false lumen like in a classic dissection. They're different beasts.
Got it. Wall problems, not tears creating new channels.
Exactly. And if an IMH is present with a PAU, it tends to be localized, probably because the surrounding atherosclerosis kind of walls it off. Studies have reported the average length of such an IMH to be pretty short, around 2.8 centimeters.
So it's a more contained issue compared to a full-blown dissection hematoma, which can track along the aorta.
Generally, yes. But does having both a PAU and an IMH together change things for the patient?
That's the key question, isn't it? Is it worse?
It appears it might be. The general consensus from the sources is that the combination of PAU and IMH could potentially be more serious, more unstable than having either condition alone.
How so?
Well, research suggests that IMHs caused by PAUs are more likely to worsen, both clinically, meaning the patient gets sicker, and radiographically, meaning it looks worse on scans. They often end up needing surgical repair more frequently than isolated IMHs.
Okay, so more likely to progress.
And surgery for a PAU with an IMH is more likely to be an urgent or even emergent procedure rather than elective.
Right. Does it affect long-term survival after repair?
Interestingly, overall survival after repair might not be significantly different, but patients with both conditions have shown a higher rate of treatment failure requiring further aortic interventions down the line, more reoperations or procedures.
That sounds like something that needs very close monitoring then, that PAU plus IMH combination.
Absolutely. Very close follow-up is key.
What about PAUs and actual aortic dissections occurring together? You mentioned TAS covers all three.
That's another important connection. PAUs can be present alongside aortic dissections in, well, up to 20% of cases.
1 in 5.
Roughly. In these situations, the initial tear in the aorta, the entry tear for the dissection, might be heavily calcified and associated with the PAU. It might not be as dynamic or obvious as in an isolated dissection.
Does that make it more dangerous?
It seems so. The risk of rupture is significantly higher when a PAU is combined with an aortic dissection compared to a dissection on its own.
Wow.
And unsurprisingly, the overall survival rates are worse for this combined group, mainly due to that increased risk of rupture.
So it's like adding fuel to the fire, having both.
That's a good way to put it. And we've already touched on the higher likelihood of abdominal aortic aneurysms. Is that the only aneurysmal connection? Does it happen in the chest too?
Good question.
Yes, patients with PAUs, whether they're in the chest or the abdomen, are just generally more likely to have coexisting aortic aneurysmal disease anywhere, including thoracic aneurysms.
So a generally weaker aorta overall.
It seems that way. Studies have reported a higher mean aortic diameter in PAU patients compared to those with acute dissections, further highlighting this association with aneurysmal disease.
It really does seem like PAUs often occur in the context of a generally more diseased, atherosclerotic, and potentially dilated aorta.
That's a fair summary, yes.
Now, how do doctors actually diagnose a PAU? We know imaging is key, but what kind of imaging is crucial?
Computed tomography angiography, CTA, is definitely considered the gold standard for diagnosing PAUs.
Gold standard, okay. What makes it so good?
It's excellent at identifying the ulcer itself, obviously, but also any associated problems. Things like thickening of the aortic wall, blood clots within the wall that thrombosed IMH. We talked about contrast leaking out of the aorta, indicating maybe a small rupture, pseudoaneurysms, and even a full catastrophic rupture.
So it sees the PAU and all the potential complications.
Exactly. On the images, a PAU typically looks like an outpouching, like a little crater coming off the aortic wall. Often has irregular, jagged edges, and it's usually surrounded by extensive atherosclerotic plaque, a calcification, and thickening.
So it's a very detailed picture they get. What exactly are doctors looking for and measuring on these scans? Is it just yes or no?
Oh no, much more than that. Besides just identifying the ulcer, CTA allows for precise measurements of its dimensions. They'll measure the maximum width of the ulcer defect, its depth, how far it penetrates from the inside of the aorta towards the outer wall, and the length of any intramural component, like an associated IMH.
And do those measurements matter?
Yes. Research has shown a correlation between larger ulcer sizes, especially depth and width, and the presence of symptoms or risk of complications.
That makes sense. Bigger might mean more instability or irritation, potentially more likely to rupture.
Plausibly, yes.
Are there any downsides to using CTA? It sounds perfect.
Well, nothing's perfect. There are a couple of key considerations. CTA uses iodinated contrast dye.
The kidney issue.
Right.
Yeah.
That contrast can potentially harm the kidneys, nephrotoxicity, especially in patients who already have kidney problems, which many of these older patients do.
Okay. And the other thing?
There's also the issue of radiation exposure with CT scans. It's not insignificant, especially if someone needs multiple scans over time for surveillance. So doctors have to carefully weigh the benefits against those risks.
Makes sense. What about other imaging techniques? Does MRI play a role here? MRA.
Magnetic resonance angiography, or MRA, has a more limited role in the acute setting.
Why is that?
Mainly due to its higher cost, the longer time it takes to perform the scan, you need patients to hold still for longer, and it's just less widely available 24/7 compared to CTA in most hospitals.
Okay, less practical for emergencies.
Right. However, MRA can be a useful adjunct, particularly in characterizing the aortic wall pathology and especially in assessing those intramural hematomas.
How does it help with IMH?
For example, MRA can sometimes help determine the age of an IMH based on the signal intensity changes of the blood products over time. That can sometimes provide more detailed information than a CTA about how acute the process is.
That sounds helpful for getting a more complete picture, maybe in less urgent cases or for follow-up. What about ultrasound? Can that be used?
Yes, transesophageal echocardiography, or TE. That's the one with the ultrasound probe passed down the esophagus to get a close-up view of the aorta and heart.
Right. How good is that for PAUs?
It's another valuable tool, although its effectiveness does depend quite a bit on the operator's skill and the patient's anatomy. With TE, PA appear as those crater-like ulcers with irregular edges, usually in an area of significant atherosclerosis.
And crucially.
And crucially, you won't see the intimal flap or the false lumen that's characteristic of an aortic dissection. That's a key differentiator.
Okay. Can it see an IMH too?
Yes, if an IMH is present alongside the PAU, TE can show it as a thickened area in the aortic wall, sometimes with inward displacement of calcium deposits.
And the advantage of TA?
A key advantage is that it allows doctors to simultaneously assess the function of the heart, Check the valves, the pump function, which CTA and MRA don't really offer in the same way.
Right, useful for the overall picture. So a range of imaging options with CTA really being the primary workhorse for diagnosis.
That's the takeaway, yes.
Okay, let's move on to the crucial part. How are PAUs actually treated? What do we do about them?
Right, treatment strategies. They really depend on whether the PAU is causing symptoms and, as we discussed, its location.
Okay, let's start with the asymptomatic ones, the incidental findings.
If a PAU is discovered incidentally in someone who isn't having any symptoms, and it's not in a super high-risk location like the ascending aorta, it's often managed conservatively, meaning without immediate surgery.
Watchful waiting.
Essentially, yes.
Hmm.
Though there are some controversial radiographic features, things seen on the scan like a diameter or depth greater than maybe 20 millimeters, that might prompt surgical consideration even in asymptomatic patients. But that's debated.
Okay, so it's generally a watchful waiting approach in many asymptomatic cases. What does that conservative management typically involve?
It usually includes strict control of blood pressure. That's paramount. Medications like beta blockers and or calcium channel blockers are key to reduce stress on the aortic wall.
Lower the pressure, lower the stress.
Exactly. Pain management is also important if there was any initial discomfort, and many patients might require narcotic pain relievers initially. Then, crucial follow-up.
How soon?
Patients who respond well to medical therapy initially will need regular follow-up imaging, typically a repeat CTA in maybe 4 to 6 weeks, to see if the aorta is remodeling, if the PAU is stable, shrinking, or unfortunately growing.
And how effective is this conservative approach? Does it usually work?
Well, the effectiveness can vary. It's not always successful long term. Some studies have reported a significant mortality rate, maybe around 10–15%, over several years in patients managed medically,
Mm-hmm.
and a substantial proportion, maybe up to 40% in some series,
Yeah.
eventually needed surgical intervention because the PAU got worse on imaging or they developed symptoms later.
So conservative isn't always curative.
Not always. However, there's also limited data suggesting that in some specific situations, like maybe a small, stable PAU that occurs with an aortic dissection but isn't the primary problem, the PAU might not progress, and patients can remain pain-free without specific intervention for the PAU itself. So it's definitely not a one-size-fits-all situation.
Right, requires careful patient selection and monitoring. What about symptomatic PAUs, the ones causing pain or other problems?
For patients experiencing symptoms, immediate anti-impulse therapy is critical, just like with dissection.
What does that involve?
It involves measures to rapidly lower blood pressure and the heart rate to reduce the force of blood flow against the weakened aortic wall. Think 5A beta blockers, maybe nitroprusside.
Okay, calm the system down immediately.
Exactly. And if there's evidence of rupture or impending rupture, things like rapid growth of the PAU on serial scans,
Yeah.
blood seen in the chest cavity hemothorax, or an expanding fluid collection around the aorta, hematoma,
Mm-hmm.
then emergent surgical intervention becomes absolutely necessary, life or death.
Right, no waiting then.
No waiting. Some patients whose pain resolves quickly with the initial medical therapy might be able to avoid immediate surgery, depending on the PAU's location and how it looks on the scan.
Right.
But for those with ongoing pain despite medication, or if the PAU is clearly expanding, or if they're hemodynamically unstable, low blood pressure shock, or if there are signs of blood clots traveling downstream, embolization, then a repeat CTA is usually performed quickly to finalize surgical planning.
And how quickly do they typically move to repair if medical management fails?
Interestingly, the median time to endovascular repair after conservative management fails is often quite short. The sources mention around just 2 days.
Wow, 48 hours. That really highlights the need for a swift response when things aren't improving or are looking unstable.
Absolutely. You can't wait around if medical therapy isn't working for a symptomatic or complicated PAU.
Now, when surgery is required, what are the options? You mentioned open repair historically.
Right. Historically, open aortic repair was the standard treatment. The first successful open repair of a ruptured PAU in the descending thoracic aorta was reported way back in 1959.
Wow, long time ago.
Yeah. And while aortic surgery has certainly become much safer over the decades, open operations on the thoracic and thoracoabdominal aorta are still big surgeries. They carry significant risks in terms of complications and mortality.
What kind of mortality rates are we talking about for open repair of PAUs?
The reported mortality rate has varied, but it's ranged from maybe 5% in elective cases in good centers up to over 20% or even higher in emergent or ruptured cases in different studies.
Those are still pretty significant numbers, especially the higher end. So has the approach shifted?
Oh, absolutely. With the advancements in endovascular therapy, using stent grafts inserted through arteries in the leg or arm, which generally has a much more favorable safety profile,
Less invasive.
much less invasive. Open repair for PAUs is now mostly reserved for specific situations, mainly for lesions in the ascending aorta and/or the aortic arch, where endovascular options are more complex or not yet fully established.
Okay, so ascending arch might still need open surgery.
Often, yes. But the majority of PAUs in the descending thoracic aorta, which is the most common location, can now be addressed with endovascular intervention. TEVAR, thoracic endovascular aortic repair.
TEVAR. But you said long-term survival wasn't necessarily more with TEVAR.
That's an important point. Studies comparing the two haven't shown a significant difference in long-term survival between patients treated with open versus endovascular repair. The main benefit of TEVAR is significantly lower early morbidity and mortality, fewer complications right after the procedure, shorter hospital stays.
So less invasive, safer upfront, especially for frail patients, but maybe similar long-term aorta-related outcomes if you survive the initial period.
That seems to be the current understanding, yes. Tell us more about this endovascular approach, TEVAR. Why is it such a game changer for PAUs?
Right, TEVAR.
It has largely become the first-line treatment, especially for those descending thoracic PAUs, simply because it's so much less invasive than cracking the chest open.
Makes sense.
And remember, the typical patient profile, older, often with multiple underlying health conditions like heart or lung disease. These patients might not be good candidates for a major open surgery.
Right, the risk of open surgery might be prohibitive.
Exactly. And given that PAUs are often focal lesions, localized problems, they are often ideally suited for treatment with an endovascular stent graft that just covers the affected area.
Like patching the pothole from the inside.
That's a great analogy. So the crucial insight is its less invasive nature makes it a much safer option for the typically older and sicker patient population affected by PAUs.
And the data supports this.
Yes, meta-analyses have shown high technical success rates for TEVAR in treating PAUs, meaning they can successfully place the graft along with lower early mortality and lower aorta-related mortality compared to historical open surgery outcomes.
Lower early mortality is key.
Definitely. And interestingly, patients with those asymptomatic PAUs who undergo elective TEVAR have shown even lower in-hospital mortality rates, sometimes less than 2%.
That sounds like a significant advantage, especially for those higher risk patients we talked about.
Yeah.
What about the long-term results after elective TEVAR? If you get through the procedure, okay.
Studies looking at long-term outcomes after elective TEVAR for PKU have generally been encouraging. One study reported favorable 7-year overall survival rates.
That's good.
However, this contrasts significantly with patients who undergo urgent or emergent TEVAR, say for rupture or acute symptoms. They have shown significantly lower long-term survival, as you might expect given their initial instability.
Right, the starting point matters hugely. Are there specific things that predict worse long-term outcomes after TEVAR for PT?
Yes, factors that have been linked to late mortality after TEVAR for PU include things like a history of congestive heart failure, having a stroke around the time of the procedure, perioperative stroke, or needing dialysis due to kidney failure. Underlying health status still plays a big role.
So, while TEVAR is less invasive, it's not without its own set of potential issues. It's still a major intervention. What kind of complications can arise specifically with TEVAR for PU?
Yeah, absolutely. Complications following TEVAR for PU are relatively common, although, again, generally less severe than those seen after open repair.
Like what?
These can include postoperative sepsis, multi-organ failure, stroke, which can happen from manipulating wires and devices in the aorta or from plaque breaking off, kidney failure from contrast or temporary low blood pressure, lung problems, and also complications related to the access vessels, the arteries in the groin usually used to insert the stent graft.
Access vessel problems, like bleeding or blockage.
Exactly. Bleeding, hematoma, dissection, or blockage of those arteries. The relatively high incidence of access vessel issues likely reflects the widespread atherosclerosis, the plaque buildup that's often present throughout the arteries in these patients. Their pipes are just generally diseased.
Makes sense. What about that really scary complication, paralysis? Spinal cord ischemia.
Right, spinal cord ischemia. It's a serious but fortunately rare complication of TEVAR, especially when covering long segments of the thoracic aorta. It has been reported after TEVAR for POR, But the good news is it often resolves, at least partially.
Is there anything done to prevent it? Like spinal drains used in open surgery?
Preoperative spinal drainage, placing a drain to lower spinal fluid pressure, is less commonly used routinely in TEVAR for PAUs compared to extensive open repairs. This is likely due to the often focal nature of most PAUs covering a shorter segment of aorta, and also the often urgent or emergent need for repair, which doesn't leave time for placing a drain beforehand.
Okay, so the urgency might preclude some preventative measures. What about the technical aspects of the TEVAR procedure itself? Are there specific challenges in placing the graft for a PAU?
Definitely. The success of any endovascular aortic intervention, TEVAR included, relies heavily on achieving good seals with the stent graft against healthy aortic wall, both above proximal and below distal, the disease segment. Getting those landing zones right is critical.
And PAUs can be in tricky spots.
They can be. If the PAU is located near the aortic arch, for instance, the stent graft might need to cover the origin of the left subclavian artery, which supplies blood to the left arm and parts of the brain.
So you can't just block that off?
Generally not recommended, no. That artery typically needs to be revascularized beforehand or simultaneously, maybe with a surgical bypass or transposing its origin. Adds complexity.
Okay, what about lower down near the gut arteries?
For PAUs involving the visceral arteries, the ones supplying the kidneys, intestines, liver, special fenestrated or branched endovascular grafts with holes or sidearms can be used. However, these are more commonly employed for aneurysmal disease and often require custom manufacturing, so they might not be readily available for urgent PAU repairs in the U.S.
So what's done then?
Hybrid approaches are an option. That's where surgeons surgically reroute blood flow to the visceral arteries first, essentially creating a longer, clear landing zone in the aorta where a standard stent graft can then be placed.
A combination of open and endovascular.
Exactly. And remember that accompanying IMH, that can also impact the quality of the seal zones, maybe making the aortic wall weaker or more irregular, and it has been associated with higher rates of reintervention later on.
So the location and any accompanying conditions like IMH can definitely complicate the procedure and maybe long-term success. What about the devices themselves? Is there a specific type of stent graft that's preferred for PAUs?
Currently there isn't one specific TEVAR device that has shown a clear advantage just for treating PAUs. The choice often depends on the anatomy, the location, and the operator's preference and experience.
How do they size it?
Generally, the chosen device is oversized by a small margin, maybe 10–20%, compared to the diameter of the healthy native aorta nearby. This helps it seal well. But aggressive ballooning after deployment to force it open is usually avoided unless there's a significant leak at the seal, what's called a type I endoleak.
Endoleak, that's blood getting back into the area that was supposed to be excluded.
Precisely. A type I endoleak is a leak at the top or bottom seal. A type 2 comes from side branches feeding back into the sac.
How common are endoleaks after TEVAR for PIU?
The incidence varies in studies, maybe 10–20% initially. Most are type I or type 2. Importantly, only a small percentage of patients actually require reintervention specifically for these endoleaks.
Do they sometimes resolve on their own?
Some type 2 leaks do, yes, but type I usually needs attention. And again, reintervention rates overall tend to be a bit higher in patients who had both a PAU and an IMH to begin with.
Okay. And what happens after the TEVAR procedure? What kind of follow-up is needed? Is it one and done?
Definitely not one and done. Post-operative imaging, typically with CTA, is essential, usually before discharge or shortly after, to confirm the stent graft is positioned correctly and that the PAU itself is excluded, ideally thrombosed or regressing.
And then long-term?
Long-term surveillance imaging is crucial. It should follow the standard guidelines for any TEVAR procedure. That usually means repeat CT scans at 1 month, 6 months, and then annually after the repair, indefinitely.
Annually for life?
Generally, yes, to monitor the graft, the seals, and the rest of the aorta. And importantly, the good news is that the symptoms associated with the PAU, the pain, for example, often resolve quite quickly after successful endovascular treatment.
That's great to hear. So a multifaceted approach to treatment, leaning heavily on endovascular repair, TEVAR for most cases, especially in the descending aorta, with lifelong surveillance needed.
That sums it up well.
Let's maybe wrap things up with a quick summary of the absolute key points we've covered about PAUs.
Sounds good. So in summary, penetrating aortic ulcers are the least common of the acute aortic syndrome pathologies, but they can definitely be life-threatening due to that risk of rupture.
Right. Small percentage, but high stakes.
Exactly. And with our aging population and the increasing use of really good cross-sectional imaging, like CTA, we're likely to see them diagnosed more frequently, including those incidental ones.
Okay. management.
Asymptomatic PAUs, especially outside the ascending aorta, can often be managed conservatively with medication and close monitoring, close imaging surveillance.
But
There should be a very low threshold for intervention, usually 2R, in symptomatic or rapidly progressing PAUs, or those with concerning features on imaging.
and the combination with IMH.
Patients who also have an intramural hematoma, along with their PAU, require particularly close monitoring because they seem to have a higher risk of deterioration and might need further interventions down the line.
Got it. And the main treatment.
Ultimately, endovascular therapy, TEVAR, is now the primary treatment approach for most PAUs, particularly in the descending aorta, provided there are adequate sealing zones, those healthy landing spots for the graft.
And don't forget follow-up.
Absolutely.
Ah,
Long-term surveillance with imaging is crucial after any repair, especially in those patients who also had an IMH.
all right. That was a really comprehensive look into a complex but increasingly understood condition. It feels like we've really unpacked PAUs.
It was clear.
Very clear. You know, considering the increasing use of advanced imaging in our aging population, it makes you wonder, how might our understanding and management of those incidentally discovered asymptomatic PAUs continue to evolve in the future? Will we treat more of them up front? Or get better at predicting which ones will cause trouble?
That's the big question, isn't it? Predicting risk is key.
Something for us all to think about. Thanks for taking this deep dive with us today.
My pleasure.